to talk to you about your background and what you do at your clinic in New York. I'd love to know more. I've done a little bit of research, but I'd like to see what you
Sure.
have to say. Yeah.
Yeah. So basically, I am a physiatrist, and I always joke that nobody knows what that is. Um, my parents are still trying to figure out what I do. But basically, we are an extension of a pelvic floor physical therapist. We are MDs, and we're non operative, and we treat the muscles, nerves, and joints of the pelvis non operatively.
Okay.
Yeah.
Okay. Physiatrist. My gynecologist mentioned that name to me one time. He's like, "Yeah, you should probably look into finding a physiatrist." I'm like, "What is that?"
Yeah, sure, I would. I would love.
Yeah, so that's great. Okay, cool.
Yeah.
Physiatrist. And do you have your own clinic or?
We do. So my husband and I founded Pelvic Rehabilitation Medicine
Okay.
in May of 2017.
Oh, very nice.
And
So new.
essentially, we started off in Manhattan, and we've grown thus far, and we're now growing. We're in Inglewood, New Jersey. We're in Long Island, as well as we're in Miami, and we're in Michigan, as
Wow.
well as in next week, in a week and a half, we're in Bethesda, Washington, D.C. area. So, yeah, so there's multiple outpatient clinics, and we're all physiatrists. And essentially, physiatrists, we take a bit more of a holistic approach to medicine. And in addition, we like to look at the entire body and its interplay. So we're not really focused on one organ system. We really try to put the entire picture together. That's really our approach with medicine in general. And also, as physiatrists, we're not technically pain doctors. We're really more obsessed with return to function. So we focus a lot on function, bowel, bladder, intercourse, exercise, sitting. And that's how we measure our progress. And that's really our whole mantra in the world of physiatry. So not just
Okay.
on pelvic rehab, but stroke rehab, traumatic brain injury rehab. It's really the fact that the nervous system can change in a positive direction and sometimes a negative direction, but its ability to change and improve someone's quality of life and function is really our whole mantra.
And that's what I love, because after I got my diagnosis of chronic pelvic pain, I got diagnosed with interstitial cystitis, pelvic floor dysfunction, and endometriosis all in 1 year. I believe I've been suffering for it for over 10 years. And I've noticed now, with being in physical therapy twice a week, that it's a whole body condition. It's not just my bladder. It's not just my bowels. Like, they're all so close together and it all interplays with one another. So it's really great to hear more about what a physiatrist does, because now I'm interested to actually going to see one, because I could totally benefit from something like that. So that's really great to hear.
Yeah, no, you're right. And then but your story, unfortunately, we hear every day, which is why we founded Pelvic Rehabilitation Medicine, really for people like you, to raise awareness, really to get you in the door earlier. Because the
Yeah.
biggest challenge, I always tell patients, it's just the chronicity of your pain. It's really hard to, our whole protocol that we do is to really reset and retrain. So we're trying to retrain the muscles and the nerves. So we're trying to really fix
Yes.
patients, not just make them feel better for 30 minutes, but to reset and retrain pain. It's better to get patients earlier. You know, the earlier we get you, the higher likelihood of getting you better really faster. Yeah. So
And that's where my physical therapist, she's been really great at explaining to me the central nervous system and how it all comes into play with pelvic pain. And she's very in tune with my needs. And she's like, I feel that your body has been put in the state for like maybe like almost a decade ago, even longer, I would say over 15 years ago. And she's like, it's going to take a while to reverse that impact that it's had on your nervous system. So even though I feel it's taking me a long time in physical therapy, I am noticing little changes, which is great, versus someone who maybe has only had pelvic pain and diagnosed with IC. They might get relief a lot faster versus me, where I've been dealing with it and my system has sort of been in this like alarm pain sort of roller coaster over the past, I guess, 15 years or so.
Totally. Yeah. It really, what happens is it becomes imprinted in your central nervous system. So it really becomes part of your messenger RNA. And then it becomes normal, and that's okay. Yeah. That's what's cool about it, though. There's neuroplasticity, right? So it can swing back to the other way. Sometimes it just takes time and continuous effort to kind of reset and retrain. But the great part is there is neuroplasticity, so it can change, which is the nice aspect, I think.
Absolutely. And that's my overall goal, is no matter, there's also, I wanted to mention that it's not just one type of therapy. Like, it's combinations of things, like you're adjusting your nutrition, you're going to physical therapy, you're also taking, I guess, pain relief medication or modulators, like I'm on Cymbalta.
Yeah.
So using it's like puzzle pieces. It's like figuring out each person what they specifically need for what their body's going through. So I've noticed that I'm seeing a lot, which is great, on Instagram, on Facebook, your website, talking all about that. And I'm super excited because my goal with the Happy Pelvis is in Canada, because I don't want a younger girl who has the same experience that I have had go through years of unexplained pain and sort of thinking that they're crazy, that something's wrong, but the doctor says, oh no, everything's fine, it's normal. And I just don't want that to happen to women in the future. So my goal is to get that information, get that awareness out there, that there are ways to combat pain. And pain is the bigger picture here, because once your body's in that cycle, you have to get back to what your body needs, I guess. Sorry, I lost my train of thought there.
No, I love that you're saying that. And I'm so happy we're collaborating, because our goals totally aligned. And I cannot agree with you more. I mean, I just think it's, unfortunately, so many of our patients, it's a chronic pelvic pain syndrome is underdiagnosed, undertreated. Patients have been turned away, told they're crazy, told that it's in their head, when clearly it's not. It's a challenge, because a lot of the issues that can cause this problem are difficult to diagnose, so that the workup can be normal, right? The cultures can be normal, the blood work, the imaging, MRI. So it's more that on the medical side, we really just need to get better at diagnosing it faster. And I think that would hopefully help at least eliminate that whole vicious chronic pain cycle that occurs.
Yes,
right? So
absolutely.
We just want to make it so that we can shorten, I think, the duration, and really start to turn people around faster. But you're completely right. You need that multifaceted, multimodal approach, right? Where really we're not just looking at one organ system by itself, or we're trying to put things together. We're understanding that whole, we call it, other than the central and peripheral sensitization, we call it the pelvic organ crosstalk, right? So if the bladder's upregulated, it can talk to the pelvic floor, and it can talk to the uterus through the spinal cord, right? There's this intraneuron connections. So if the bladder is upregulated, quite often your uterus can be, your pelvic floor can be, any of the surrounding structures, not just organs, but fascia, muscles.
So confusing
it's very confusing. So, and it gets more challenging the longer the pain is there. So sometimes when we meet patients, our goal really is to calm them down, so that we can really find out what is that underlying primary pain generator, right? What is it? If there is one, we got to calm you down, and then we'll see. It really can come to light once we get patients a bit better with what we do. And our protocol really is for patients who either plateaued in pelvic. We always start with pelvic floor physical therapy if they haven't tried it. That's be our first place. But the protocol that really I created was for patients who, plateaued in pelvic floor physical therapy or failed to progress. So pelvic floor physical therapy got you about 50% or 70% of the way, but not quite 100%. So then that's when we would come into play. So trying to get patients 100%, right? But we want to get their quality of life back to exactly where it was before. Pain-free, exercising, having intercourse.
That's my goal.
Yeah.
That's my journey right now.
What we would treat patients who've done some pelvic floor physical therapy, and they've had significant improvement, but they're not 100%. Then they would see us. And so we're the non-operative approach to really get you to 100%.
Okay.
That's really that's the protocol that we do. That's what we're doing.
Do you work with other specialists, other
100%.
doctors?
I mean,
Okay.
we never claim to get people better on our own. Normally what we do is we start with, we try to figure out what's going on, and every patient's different. And we do see men too. So we see men and women.
Okay. Yeah.
But, was it postpartum, your vaginal delivery, or is there high suspicion for endometriosis or fibroids or adenomyosis, something gynecological, or something GI? Do we think it's potentially Crohn's ulcerative colitis that's irritating, or just IBS,
Yeah.
or something bladder? Do we think there's IC or not, or just overactive bladder? So we're really detectives here as physiatrists. We are kind of in the quarterbacks, because at this point we are the ones looking at the whole body, and then we're developing a team. We always have pelvic floor PT on board. We don't treat anyone without it, because we're just an extension of PT, really. So we always have a PT, but then it's, do you think we need a gynecologist? Do you think we also need GI? And every patient's different. We listen, and then we sum it up and we make a plan and we build a team. But it's always a team approach. And then everybody's meditating. We did bring mindfulness-based CBT in-house via a telemedicine platform, which is super exciting.
Cool.
So she does this mindfulness CBT, sometimes hypnosis too, whatever a patient needs, to really help calm down the descending signals from the brain. And then we'll use medications as needed as well. CNS neuromodulators. We use some Valium suppositories for our patients if they're in spasm as well, that can help.
Yeah.
Warm baths, where we have a specific yoga program we use. Basically, when we get you better, we are big believers in self-efficacy, of kind of treating yourself and learning if a dilator or a wand and a specific yoga program to help hold all that progress that we've made. And the yoga we find for most people is great. A restorative program, Your Pace Yoga is one we usually use. Dusty Ann Miller, she's excellent for pelvic floor, and more of a restorative approach. And then for certain patients, it's more Pilates. It really depends. If they have some laxity, sometimes we'll say more Pilates. But yeah, we do really want to keep patients exercising and moving and functioning.
Like that is something that I know that is in my future. I need something like that. So that's so great to hear that others who are in my shoes are getting that approach and that hands-on. Like you are in our on our team, because as a patient, sometimes it's very hard to discuss with certain physicians our issues, because we might not be taken seriously enough. I know that was one topic we wanted to talk about pelvic pain patients in general, because there's lack of knowledge, getting dismissed by doctors, and doctors not having knowledge about the pelvic floor nerves and muscles. So I think it's really great that you work with other specialties, because in Canada, from my experience within the last few years directly, there's no communication between each of the specialties. So my PT, she works with me twice a week. I see her the most, and then she'll send a letter to my doctor talking about my progress, but there's no there's no discussion or collaboration thinking, okay, the next steps. So I think it's really great that physiatrists do exist for our pelvic pain issues, because I think that's absolutely something that we need. We need you guys in our court, so it makes me happy to hear.
Thank you.
And the difference in Canada versus the States, I know our wait times to see a physician are fairly long. In New York specifically, or anywhere else on any other of your clinics, do you feel that is an issue, or it's...
No. I mean, when you call our clinic, you can get, it's almost always same day, even, definitely within the week. But to see us, yeah, a lot of times it's same day actually, but within the week particularly if you're not specific as to I have to see XY doctor, but for pelvic rehabilitation medicine, we get you in within the week. For the other specialists, maybe a couple weeks is the most, but no, it's not an issue.
Okay, because we notice here
for most. I can't speak for all. I mean,
yeah.
I think some, there are some where it's a couple months wait, but nothing beyond that.
Whereas I feel with Canada, which I loved the like family physicians to know, like you were discussing earlier, is starting earlier. So seeing if you have a patient who has recurrent UTIs, who has a lot of pelvic pain, if a family physician were to know that pelvic floor physiotherapy can help potentially in this circumstance, like that is something that definitely needs to change here in Canada. But I see in the States, it works a little bit differently. So it might not, I don't know about the family physicians when they're referring to.
No, I think there are similarities in terms of, it's not necessarily the wait time, but what I think is challenging is really just diagnosing, figuring it out, and what over the years now of treating this for quite some time, what I usually say to the front lines people, which are either the general gynecologists or the primary care doctors who are doing, the Pap smears, is any patient who has pain with your examination, with your speculum exam, that's probably someone to consider referring, because it shouldn't, hurt most people, or the person that you have to go get the pediatric speculum for.
Yes.
So that's been, or a patient who tells you, a younger tampons bother them. That's also another one. It's kind of catch it. That's because I think if you can figure out how to catch it, then we can really refer faster. And that's usually when I'm ever, giving talks or speaking with anybody, that's usually what I say. Same with that speculum exam. You may want to rethink, you may want to think, do they need to see a physiatrist or pelvic floor physical therapist to check it out, to see what's going on there.
Okay. Yeah, that's very interesting, because when I was growing up and I would do those exams, that was the issue. I would have pain and she'd be like, oh, that hurts. Oh, let me get the pediatric one.
That's it. See, I'm telling you, that's it.
I totally, yeah. So I relate to your patients. Absolutely. Like there's times where my doctor has said, oh, that shouldn't hurt. I said, but it does hurt. So can we figure out why? Right. And that's what I never got. And that's what I feel in my healthcare was lacking. So I'm hoping what I'm doing is spreading the word, and getting the word out there.
Maybe you can help me spread that then, because that's what I've been spreading, and that seems to be helping. People seem to, oh, that's the patients that you could help. I see. Okay.
Yeah. And I'm sure that there's, now that I've started this community, I'm seeing that there's so many of us, whereas before I thought I was alone. I thought nobody I knew had issues with intercourse or recurrent urinary tract infections that they just couldn't get a handle on. But nobody would know this was going on, but I would just push past it, and I would really get down on myself and feel that there must be something wrong with me. At the end of the day, that's what I thought. And when I got my diagnosis and started searching online, the word IC was thrown around actually by a naturopath I had years ago. And I never actually, we never really went that path, but she brought it up. Anyways, long story short, I got a little bit better. And then once my IC and my chronic pelvic pain became a daily dilemma where I was not able to work, I had to go on disability. Well, thank you. It's been difficult. So creating this Happy Pelvis community has allowed me to really see that this is an issue, and there's a huge gap in the care for pelvic pain patients. So hopefully with the years coming, as I'm getting the word out, hopefully with your help, and we can work together, and things will get better for pelvic pain patients, because it's not just physical pain, it's emotional too. And
100%.
It depends on your personality. So if somebody already has a predisposition of depression or anxiety, this is just gonna amplify it. And that's what I noticed with myself. I never really noticed I had anxiety until this happened. And then I look back and I'm like, oh, okay, all of the ducks are in, or I'm like, everything's sort of coming together and making sense. And I guess that's what you do. You start picking the pieces of someone's health history and their whole body in general, and you try to give them the answer they're so desperately needing. And that's where I just asked my doctor, I'm like, there has to be something wrong with me. Like, I can't go on every week getting a urinary tract infection. They would use the term, every doctor I saw was, you need to make sure your hygiene is tip-top, wiped front to back. I'm like, I am the cleanest person, especially because I get UTIs. Like, there's no way. But anyways, now I know it was a hypertonic pelvic floor that was causing that. So now that I'm learning all of this, I just want to help people as much as I can, at least guide them in the right direction. I know I'm not a specialist. I don't have the knowledge that you guys have, but just connecting people would be great to do, and help others.
No, I commend what you're doing. It's amazing work, honestly. And think of how many patients you're helping, really. So it's really, really
Thank
cool
you.
that you're following your passion and trying to make a change and a difference.
Thank you.
Really
You too.
cool.
Like
Really cool stuff.
you're helping so many of us, and I really appreciate that.
Yeah, no, I mean, I actually got into this as well because I had my own issues. I think a lot of us that's why I kind of
Okay.
this is a postpartum issue after having my first baby. So
Okay.
a lot of my patients were like, I can tell you really get it when I'm explaining my urgency and my frequency.
Like, I've been in your shoes.
You really understand. So yes, no, I haven't been in the shoes. I've been ignored, etc. And
Okay.
I've been there. Yeah, but I think that's what drove me to try to figure out a better way to get better faster.
So thank you for that.
Yeah.
Just see. Is there any questions you wanted to ask me specifically about the care I get here? Or anything personal?
Yeah. No, I think what would you say has really helped you the most? You've mentioned pelvic floor PT. I'm just curious, what do you think has helped you the most thus far? Make progress and gains that you've made?
I would have to say pelvic floor physiotherapy, number one.
Yeah.
The second one, I'm not proud to say, but the best thing for me when I am in my debilitating painful flares is the suppository that has Valium, gabapentin. It's a compound suppository.
Cool. Wow, that totally works. Yeah.
So that's my go-to.
Yep.
And keeping up with stretching.
Yeah.
If
Right.
I don't stretch, I know that's part of physical therapy, but if I don't take part in that, then I flare up. I notice the tension building up. I notice my bladder getting irritated, and everything goes downhill. But but I'm still actually in the works of finding my root cause and figuring out and ruling out different things. So today, for example,
are?
I am.
Okay.
I am. So, I have the endometriosis confirmed diagnosis through laparoscopic excision. I was diagnosed with IC bladder pain syndrome because there was no visible ulcers on my bladder. And then I was diagnosed with hypertonic pelvic floor by my pelvic floor physiotherapist. So pelvic floor PT has helped me the most. And so, for example, this morning I went to a gastroenterologist. So I noticed there's a big correlation between my bladder pain and sensations and my bowels. So I went to see him, and he's looking into the different, if it could be IBD, Crohn's, something along those lines, because I noticed there is that connection. So I'd love to know if there is something going on there. And if not, then I can sort of go in the direction, maybe my nerves in that area are just misfiring and going off due to my pelvic pain. So I'm still putting the pieces together. My mother has lupus and rheumatoid arthritis. So I've seen a rheumatologist, and my blood work is showing towards lupus, but it's very hard to get a confirmed lupus diagnosis unless you're in a full-blown lupus flare and do that blood test, he was saying. Yeah. So that could play a role. So autoimmunity for me, in my personal experience and my life, that's where the direction I'm going, but there's so many reasons for pelvic pain. So that's another big issue I'm tackling is if I discuss something on my page personally about my journey, other people, there'll be 10 people saying, well, I get this. I do, like, there's so many different things, and the message that every single body is different needs to get across as well, because your body is so complex. And that education is something that I feel patients also need to be aware of too. They can't just expect to go to a doctor and them know the answer right then and there. But anyways,
I completely agree. I mean, it's a complex disease process, chronic pelvic pain. And like we had mentioned, there's a large interplay between many organ systems as well as the muscles, fascia, and the joints. So you're right. It is complex, and every patient is completely individual. So I think a lot of the key in pelvic pain from a practitioner standpoint is really listening. It's just really just trying to listen and figure out from the patient's history and exam the primary pain generator. Whenever I'm training physicians, it's really that. Like, you are a detective, and unfortunately we don't have a lot of times the imaging, et cetera, like other fields do. So we really have to listen, do a proper exam, and try our best to figure out where we think it's coming from. And then once you kind of can figure that out, it really helps. It really helps get the patient better. Yeah.
Yes. And I feel that's also physically knowing an answer to why you're feeling the way you're feeling is a huge weight off someone's shoulders. So getting to that journey, getting through that path is treacherous, especially here in Canada, because when you do see a physician, they see a lot of patients during the day. They see too many patients, and that's just how our healthcare system is working. So they don't have the time to sit with you and go through and talk with you and get those little details here and there. They have about 5-10 minutes maybe, and then they're ushering you out the door, maybe with a blood work or another test, and then comes in the next patient. So that's also a difficult thing here in Canada that I'm noticing is changing though. I feel like they are here and I'm finding them, but it's up to me. I have to take the initiative. I have to advocate for myself in order to find a doctor who will take the time to help me.
I think that's everywhere. Yeah, I encourage patients to be their own advocate, particularly with pelvic pain. You really have to be your own advocate at this point and know that, it's not in your head, and there is help out there. There really is. There are more and more resources popping up every day, hence also why we're going to multiple cities, because people fly and see us really from all over, honestly, at this point, even all over the world, but definitely all over the United States. So we are kind of now bringing the care to them. We're excited to do that because patients need it and deserve it.
I love that. It makes me really happy to hear. I'm going to tear up because the care here, it's getting better. There are a lot of programs that are starting a lot of pelvic floor PT. Like my personal pelvic floor PT was explaining that pelvic physio wasn't really the focus in school. And if you wanted to do pelvic floor physical therapy, it was like a niche, and not many individuals went that route.
Right.
But she's noticing more and more that people are wanting to, because of being able to help someone who just had a child, who is going through all those emotions, and knowing like it's all normal. Like, you're not, like, everybody's going through it.
Yes. Yeah, definitely. I love when I get patients from France, like my French patients. They're like, oh, so great to see you. Tell me what brought you in. And they're like, what do you mean? I had a baby. Of course I'm going to come in and get my pelvic.
Oh, yes.
Like, that's amazing. I love that thought process.
I think Sweden and
France, Sweden, maybe Denmark as well. But yes, they are, it's part of their culture, and I think it's fantastic. So I'm hoping that Canada and America will adopt that.
Absolutely. We got to bring that over here.
Bring it over here.
Yeah. Like my sister, for example, she just had her second, and before all of this, I didn't know about pelvic floor physiotherapy, but now that I'm learning, I'm like, you need to go. Like, you're going to get so much relief. You're going to not be all stressed out. Like, it'll help. And so she's going to go. So I'm the advocate for PT. Whenever people complain or come to me and say, oh, this is happening, what do you think? I'm like, try pelvic floor PT.
Totally. Start there.
Yeah.
Great. No, that's great. Well, I think you're doing amazing work. And
Thank you very much.
congratulations to you with
Thank you.
everything you're doing. And thank you for doing it.
Oh, well, thank you. When I first got my IC diagnosis, I was referred to a pain clinic.
Okay.
And they, here in Canada, I think North America, there's the opioid crisis going on. And so they avoided giving me painkillers. So I'm wondering, do you give marijuana prescription, like in New York? I know each state is different. I'd like to know, do you find cannabis or marijuana beneficial for your patients, or have you noticed that it helps with their moods more so than the pain? Or do you have any experience with patients who use cannabis for their chronic pain instead of?
Yeah. Honestly, we don't prescribe it ourselves, but I do for certain patients refer for a prescription from a doctor who does prescribe it. I've seen it. I find it's patient specific, as a lot of the medications are, but some of my patients, it's been amazing, particularly patients who are already on opioids who come and we're looking to wean them off, which is what we do in general, wean off. So I find that that's been helpful to wean patients off opioids is the medical marijuana. Some patients love it, others don't. It's completely, I think it's patient specific, but some patients have really found it's helped. What patients overall do seem to like and find a bit helpful is the CBD suppositories, which again, they can get online. They don't need a prescription from me, but they can order it online. And sometimes we'll do like a combination, and we'll do Valium, baclofen, and gabapentin, and sometimes Termeel, so arnica at night in a suppository, and then in the morning they'll take a CBD suppository. So we use it that way. I think it sometimes takes the edge off. I mean, like I said, there's no silver bullet with pelvic pain, but I've seen those CBD suppositories. Patients tell me they take the edge off, and then also some patients use the CBD oil. I usually also really like that CBD oil for either if they have a bit of kind of rectal burning or rectal pain from their endometriosis or pudendal nerve. I'll usually say, try a little of the CBD oil perirectally, and that sometimes helps. Or you can put the CBD oil on your abdomen to desensitize all those abdominal nerves. I find that can help a bit if they find it soothing. Sometimes they'll do CBD oil with some magnesium oil combo, which I like. Yeah. And then also they can do the tincture as well of the CBD. Some of my patients say that helps a bit. So most of my patients are more into the CBD suppositories, oil, and tinctures overall. I'd say that's very, very, very common in my patient population, and it definitely seems to help in combination with everything else we do, right? With the all the puzzle pieces, warm baths, physical therapy, the injection protocol, with that. But with the medical marijuana, I usually save that for my more challenging patients and those who are trying to get off opioids. I'll suggest that. I say, why don't I refer you out to see if medical marijuana may help? And a lot of times it does. So overall, I think it's been a nice asset and another kind of tool that pelvic pain doctors have in our toolbox. That's how I look at it. As another tool. So, which is great because we need more tools.
Exactly. We're running out of, we need other options.
So overall, I think it's been fantastic.
Yeah. Okay. That's good to know. Yeah. Because here in Canada, because it was legalized in each of the provinces, I've noticed at the pain clinic, that's the direction they're pushing patients towards the cannabis use. And they're also wanting to find more research. And they reached out to me to do surveys to figure out, because they're like their patients are their best research, best thing to research, because they're the ones with the pelvic pain and using cannabis. So anyways, I was wondering to see in the States if things were a little bit different, but here that's what they're pushing for as well, which is good to see, because
I completely agree. Yeah, I mean, at Pelvic Rehabilitation Medicine, we don't prescribe opioids at all. We're totally non-opioid policy. Mainly because they really can cause some rebound hyperalgesia, meaning that their sensitization gets worse, and constipation. And for pelvic floor, constipation is like our enemy of the pelvic floor. So for us, they don't really help. They don't help our patients. So I definitely would defer more towards the medical marijuana if patients are at that point, for sure. I think it just makes more sense for our patient population.
Okay, cool. Thank you for explaining that. Would you ever be up for opening something in Canada down the years down the line?
Oh gosh. You never say never. I mean, my mom is Canadian. So.
Oh, really?
Yes. My grandparents are Canadian from Nova Scotia. So
cool.
I spent many summers in Prince Edward Island. So,
very beautiful.
Yes,
Beautiful spot.
Beautiful country. So I can never say never.
I know. Don't mean to put you on the spot. I just wanted to
I do love
there. Well, thank you very much for taking time out of your day to talk to me and answer some of our questions and discuss. And that was really helpful. So I hope we can stay in contact. And if there's anything that you need help with, or if you have any ideas, feel free. I mean,
one plug is we are doing research on our own as well. We are doing research on the IRB approved protocol through the Feinstein Medical Institute that I had mentioned that I created. But also in addition to that, we're part of the ROSE trial. So it's research outsmarts endometriosis. Okay. What we're trying to do is help find a diagnosis for endometriosis through menstrual blood flow. So they're trying to analyze the biomarkers in the menstrual blood flow. Now, we have a new collection device that was created by the geneticists, Drs. Gregerson and Metz, which is basically like a pad. It's like a pad overnight. You put it on and it collects your menstrual blood flow, and then you send it back into them. And essentially, we're trying to get people to participate. So what we need is people either who have a known diagnosis of endometriosis, patients who just have a suspicion and are currently considering a laparoscopic surgery to take a look. And we also need control subjects. So we basically, any woman can participate.
I'm up for it.
I mean, it's like such a great thing, and I would love to get more people interested and excited and care enough to try to help find a diagnosis. And now it won't help just you right now. It's going to be a genetic analysis, but it will help any nieces, that you have further, if you do have any children. So we'll help the next generation, and you do get $50 for participating. So I really want more people to try and help us. So I'd like to put a plug in for the
absolutely
trial.
That's simple enough for me to do, and that would be incredible if they can find a marker in there.
Exactly. Then we don't have to. Exactly. We don't have to do surgery. So if you're interested, you just you can email contact@pelvicrehabilitation.com. So it's Pelvic Rehabilitation Medicine is the name of our clinics. You can just Google us, and then their email's there, and just shoot us an email if you're interested in being part of the ROSE trial. Let us know.
Awesome. That is so wonderful to hear. Thank you. I will definitely reach out.
Yeah, well, I hope we can keep in touch. It was a great conversation.
Definitely. Thank you very much for taking the time.